And we're back, baby. 176. For those of you new to the series, I'll be teaching the topics that you need to know at this point in your prep. All these questions are original. The first tip I want to give you for 176 is about translation. They might ask you, okay, can you translate? You know a little bit of Spanish you took in high school? The answer is no. You need an actual bona fide translator. That was easy. That's 176. Next, 177. 4-year-old boy is brought to the clinic due to poor appetite, fatigue, and behavioral regression. Anytime you have a rental home in the 1960s, we're thinking about lead poisoning. He's got some pallor and ataxic gait. Which enzyme is inhibited? Okay, so lead poisoning in the children interferes with heme biosynthesis, and that causes anemia, abdominal pain, and neurologic symptoms. And so you'll see somebody who lives in an old house, 1976, I think is the cutoff date. It'll cause anemia, abdominal pain, neurological symptoms. You might see constipation, irritability. By the way, here's the green screen. And you're going to see elevated 5-levulinic acid. Now, this is a decent photo here. We've looked at this before. There's the mitochondria, the cytoplasm. Lead inhibits ALA dehydratase. And if that's inhibited, which by the way is also known as porphobilinogen synthase, then you'll get increasing amounts of ALA. What also is inhibited? Well, definitely not this. It's the aminolevulinic acid dehydratase that's inhibited. There's one more thing as well that's inhibited, and that's ferrochelatase, because that's what catalyzes the final step in the heme synthesis. So we got our glycine, comes over, creates 5-ALA, and that's what's deficient here, inhibited by lead. So we don't have ALA dehydratase, so you don't get this photobilinogen, porphobilinogen action, but also this ferrochelatase is inhibited as well. So that's all going to result in decreased heme synthesis and increased ALA. So when ferrochelatase is inhibited, you have protoporphyrin that accumulates everywhere because you need ferrochelatase to go to heme. So protoporphyrin is everywhere and the heme decreases, you get anemia, and then zinc gets incorporated instead. And that leads to zinc protoporphyrin elevation. So in lead poisoning, to put this all together, we see a couple of things. Increased 5-ALA, increased zinc protoporphyrin, decreased heme synthesis, and then normocytic or microcytic hypochromic anemia. Here's a walkthrough of the answer choices. Here we have a 4-year-old boy for 178 who's brought to the clinic by his parents due to recurrent mucoid discharge from a small opening on the left side of his neck, anterior to the sternocleidomastoid. Discharge is more common when you've had an upper respiratory infection. There's a small pit. What's the origin of this? This is a congenital neck mass caused by incomplete fusion and obliteration of the branchial cleft during embryonic development. You know that because of the location. It's on the lateral neck anterior to the sternocleidomastoid. It does not move with swallowing, unlike the Thyroglossal duct. So the Thyroglossal duct cyst, that one would move when you swallow and it's more midline. This guy is to the side. And it also can have a fistula, so it has the draining tract to the skin and it can get infected. So if they were to change this question around, they said, hey, we got something and it's midline. If it were midline, then that would be the Thyroglossal duct cyst. It's lateral and so it's got that fistula as well. So it's the failure of the involution of the second branchial cleft. Normally obliterated, but it can cause cyst, sinus, and fistula. Thyroglossal duct, midline, moves with swallowing, not lateral. And then the first pouch forms middle ear structures, and lateral neck folds, not a source. Okay, here's our frontal bone, nasal cavity. There's the superior, middle, and the nasal cavities right here. So you breathe in, you have the external nares. Hard palate is up here. Here's the soft palate in the back. There's the epiglottis. Glottis is down here. Vocal fold. Your oropharynx. Nasopharynx is up here. Oro, naso. And there's our sphenoid, sinus, and frontal. All right, so 179. We have a 43-year-old man, ENT clinic with recurrent left-sided facial pressure, nasal congestion, postnasal drip that worsens after upper respiratory infections. He's diagnosed with chronic maxillary sinusitis. During nasopharyngoscopy, a mucopurulent drainage is seen from the middle nasal meatus, which the following best describes the anatomic location into the affected sinus drains. All right, so here's our semilunar hiatus. You can see it again in this photo, and that's where this is going to drain. The reason is the maxillary sinus drains to the middle nasal. There's the semilunar hiatus, and this is a really good photo right here. Ethmoidal recess, middle concha, superior concha, right there. So the sphenoethmoidal recess is the place where the upper part of the nasal cavity, where you have the two sinuses that drain, that's your sphenoid sinus and the posterior ethmoid air cells. So the superior and the posterior to the superior nasal concha are going to be draining there. And so you have pus that drains from the sphenoethmoidal recess, which causes, indicates the infection, and posterior ethmoid sinuses is going to drain into that area. Sphenoethmoidal recess. There it is again, superior meatus, and then it's superior to that, the sphenoethmoidal recess. Whereas the frontal maxillary ethmoids, these guys are middle, and inferior is nasolacrimal. All right, next up, 180, we have a 12-year-old boy, goes to the clinic 6 weeks after fracturing his tibia. He's been in a cast, now has minimal pain, and is walking with assistance. Follow-up radiograph shows a sign of callus formation with remodeling of woven bone into laminar bone. Which of the following cell types is primarily responsible for remodeling the newly formed bone matrix during this stage? Remodeling would be the osteoclast. After fracture, bone healing progresses from hematoma and inflammation to fibrocartilaginous callus, formed by the woven bone formation and remodeling into the laminar bone. Osteoclasts reabsorb that disorganized woven bone and reshape it in the remodeling phase, and the blasts lay it down, but the clasts remove it. And I think it's important to talk about the periosteum. So that's a thin but very tough outer layer that covers the bones. It's like a protective sleeve that the bones wear. And it contains mostly blood vessels, but also nerves and, most importantly, the stem cells. And these are the osteoprogenitor cells. And these cells become osteoblasts. They build new bone. And whenever you get a bone break, you get bleeding, inflammation at the site. That makes sense, right? That's the hematoma formation. And the periosteum and the endosteum, they send the stem cells in to start the healing process. And you get a soft callus. That's the fibrocartilage that forms and becomes hard bone. It ossifies over time. So first that soft callus then hardens, and then the bone is reshaped into a normal bone, and that's the remodeling phase. And now at the end of the bone, there's this thing called the epiphysis. That's important for the growth in children. One must think of epiphysis as happy. Just kidding. So yeah, that's the growth in children, and it's not used for fracture healing. The Haversian canal is part of the compact bone that holds the blood vessels, but it doesn't actually generate new stuff. And you might be wondering, hey, what's the lamella? Those are the rings of the bone matrix around the Haversian canals. They're structural. They do not regenerate. And you've also heard probably of something called the Volkswagen. Well, there's also the Volkmann canal. That connects blood vessels across the osteons, and it helps to supply, but it does not actually help with the healing stuff. The periosteum provides the stem cells that then become osteoblasts, which are then essential for the fracture healing. So our incorrect answer is chondrocytes. Those are involved in fibrocartilage callus formation. Osteoblasts form the new bone. Fibroblasts produce collagen. Mesenchymal stem cells give rise to osteoblasts and chondrocytes, but they are precursors, not active remodelers. So the osteoclasts help to remodel. But knowing that process is important. First, laying down whenever you have a fracture, that starts with the hematoma and then the inflammation growth factor. Then you have the fibrocartilaginous soft callus that gets deposited, and then it ossifies, and that's how the remodeling process. That's all done by the periosteal cells and osteal cells that help with the repair process. All right, for 181, we're going to talk about CERM. There's a 28-year-old woman evaluation for infertility, trying to conceive 14 months without success. Menses are irregular every 40 to 60 days. Pelvic ultrasound shows small follicles on both ovaries. She started on medication that induces ovulation by modulating the hypothalamic pituitary ovarian axis. What describes the mechanism of action here? So it sounds like she has polycystic ovarian syndrome. And before we get into this, I want to talk about clomiphene. Now, this binds to estrogen receptors in the hypothalamus and the pituitary, and it blocks estrogen's negative feedback. And so then the body's like, oh my gosh, estrogen's low. And what do you think the body's going to do if it thinks that estrogen is low? Well, it's going to boost its production of the follicle stimulating hormone. That's the clever trick here. That will stimulate the follicular growth in the ovary and also the luteinizing hormone, which triggers the ovulation. And the result is you get more follicles that mature. And so ovulation is induced, and that's essential for conception, right? And that will increase your chances of pregnancy. So you get more FSH and you get more LH when you give clomiphene. So clomiphene is a selective estrogen receptor modulator. That's why it's called CERM. It's anti-estrogenic at the hypothalamus and pituitary, but it can have estrogenic effects everywhere else. It's used in anovular infertility. So you typically give this to somebody who has polycystic ovarian syndrome, which is what our patient has, and it's taken early in the menstrual cycle, usually like days 3 to 7. So the mechanism of action of the medication is a CERM, estrogen receptor antagonist in the hypothalamus. Boo. All right, for this next question, let's do some anatomy real quick. Uterus, cervix, pseudojugular, rectum. There's the pelvic sidewall, uterosacral ligament right here, and the round ligament over here. There's the ovarian ligament, fallopian tube, and the ovary. There's our rectouterine pouch. Some of you are saying this all makes sense now. Well, let's put that to the test. A 29-year-old woman presents to the emergency department with sudden onset right lower quadrant pain and light bleeding. She's sexually active and inconsistent contraceptive use. Her late menstrual period was 8 weeks ago. Pale diaphoretic blood pressure of 85/50. Wow. Pelvic exam shows cervical motion, tenderness, and moderate nexal tenderness on the right. This is probably an ectopic pregnancy. What's the complication occurring? Okay, now we have to figure out which one it is. Well, we have amenorrhea, so that's 8 weeks ago. There's a positive pregnancy test, so she is indeed pregnant. And hemodynamic instability, because that 85/50. And adnexal tenderness. So this could be an ectopic pregnancy that has ruptured. And that would cause hemoperitoneum, which is bleeding in the abdominal cavity, and that would cause the hemodynamic instability. And so the fallopian tube is the most common site of the ectopic implantation. And the fallopian tube is another way of saying the uterine tube. So it's probably a tube rupture. Incomplete abortion would show intrauterine pregnancy. Ovarian torsion would show pain and adnexal mass, but no pregnancy. Important. The appendix perforation would cause right lower quadrant pain, but not vaginal bleeding. Endometrial carcinoma presents with bleeding, not acute pain and shock. 95% of ectopic pregnancies implant in the fallopian tube. And the risk factors are pelvic inflammatory diseases like PID, that's a big one to look out for. Also tubal surgery, endometriosis, and infertility treatments. All that stuff can cause these things to happen with more frequency. Super rare to have it in the cervix, and ovarian ectopics do exist, but they're a lot less common than the tubule. It's often not in the rectouterine pouch. That's where you collect the blood from the ruptured ectopic, but it's not going to be the site of the implantation, and definitely not the appendix. That would cause right lower quadrant pain, and typically also you'd see like a fever or something else associated with it. So ectopic pregnancy, especially in somebody with delayed menses, pelvic pain, and a history of pelvic inflammatory disease, almost always means that there's a fallopian tube involved. So it's like the tubal involvement. And this is just super important to know, super high yield. All right, next question. This is going to be super simple. Just incidence versus prevalence. 4,000 factory workers for latent tuberculosis. Baseline 600 are positive, and then 160 test positive. What's the approximate annual incidence? So the only tricky thing is we take the 600 out of the 4,000, and that brings the total to 3,400, and then it's a 160 out of those, so approximately 4%. That's a correct answer. All right, folks, we're going to do this one good. Let's talk about your boy, Giardia. So this is going to be transmitted through the fecal-oral route, usually through contaminated water or food. Giardia intestinalis forms infectious cysts, and typically you see this in hikers and campers because they're just drinking water. Who hasn't done that at one point? Is that a common experience with your friends at scout camp, just like drinking river water? Anyways, poorly purified and untreated water is a common vehicle for Giardia intestinalis transmission. And this is going to cause really bad, foul-smelling, greasy, non-bloody diarrhea. This can also impair nutrient absorption, and that can cause steatorrhea. And that means there's excess fat in the stools. And so Giardia can also cause your fat melt. And also the guys look really weird. It's like a little dude, like a little shield or something. I don't know how to describe it, but once you see it, it's a trophozoite shield looking thing. It looks like a pear, and just know that. Now you can see this in the cyst or the trophozoites in stool specimens. You do a stool, ova, and parasite examination. The treatment is going to be metronidazole, tinidazole, and nitazoxanide. So just know you can treat this with the Metro. Okay, let's see if I prepared you for this question. A 34-year-old backpacker. Yep, Giardia. South America, greasy, foul-smelling diarrhea, flagellated pear shape. That's just absolutely pathognomonic. Holy cow. Easy as it can possibly be. Which mechanism explains this patient's symptoms? Disruption of the intestinal border. We got Giardia. Malabsorption due to disruption, fatty diarrhea, all that stuff. Hikers, campers, foul-smelling, greasy diarrhea, bloating, weight loss, fat-soluble vitamin deficiencies, all that stuff. Giardia. Could be a beautiful name. Kind of like diarrhea, Giardia. Beautiful names. Giardia. All right, moving on to 185. So in this question, we have a 42-year-old man with HIV is found to have rising viral load despite a strict adherence to his antiviral regimen. He's on emtricitabine and tenofovir. There's a mutation in the gene encoding HIV protease. Which step is most likely impaired? The cleavage into the functional protein, because that's what it does. Ritonavir and the navirs, they're protease inhibitors. It stops the cleaving of the GAG-PAL polyproteins, which is needed to make the mature virions. It's the assembly maturation step that's affected. Reverse transcription is the NRTIs and NNRTIs. Integration is the integrators, tegravirs. Fusion is the fuver, so fuvertide. And transcription is carried out by the host machinery. So you'll see somebody who's HIV positive. They have a CD4 count that is dropping, increased viral load. And so what we have here is drug resistance. This is due to mutations of reverse transcriptase enzyme. And then we just have to recognize NRTIs when we see them, like zidovudine, lamivudine, and then NNRTI. Remember, out of the den, E, efavirenz, and these three will target HIV reverse transcriptase. And that step of the reverse transcriptase is super error prone in HIV viral replication. And that can cause the mutations and viral resistance. Okay, in this next question, 186, we have a 17-year-old girl presenting to the emergency department with widespread urticaria, difficulty breathing 15 minutes after eating a meal that includes shrimp. She's got a history of atopic dermatitis. On examination, she's got diffuse wheals in her trunk and limbs, inspiratory stridor, and epinephrine is administered. What's most likely responsible for sustaining the patient's symptoms hours after the allergen? Now, before we dive into this, let's talk about our hypersensitivities. There's an immediate allergic reaction, and that's commonly mediated by mast cells and also IgE. So there's an immediate phase that's seconds in, and you have preformed histamine tryptase, and that causes vasodilation and itchiness. That's within seconds. And there's a late phase that's hours later, and there you have newly synthesized prostaglandins, and these guys prolong the inflammation, and they also cause the swelling and the pain. So first you have the preformed mast cells, histamine, tryptase, And then you have the prostaglandins and leukotrienes. So the preformed granules secrete histamines and tryptase immediately. And the newly synthesized, or the de novo created ones, cause prostaglandins and leukotrienes, and that's the sustained stuff. And so prostaglandins, especially PGD2, are synthesized de novo from arachidonic acid through the COX pathway of the mast cells. And so looking at our answer choices, hours after would not be the histamine, or the T cells for interleukin, or immunoglobulin A, or TNF alpha, it would be the leukotriene. It's the late phase. So these guys cause bronchoconstriction, increased vascular permeability, and mucus production as well. Not TNF alpha, that's produced in late phase, but mainly promotes inflammation and neutrophil recruitment. Leukotrienes are more direct in the vascular changes. All right, for this one, we're going to be looking at our musculocutaneous nerve on the brachial plexus. There it is in all of its glory. MMRU from the lateral, 5 to 7 lateral, 5 to 8 posterior, 8 to T1 ulnar. Musculocutaneous. Okay, let's do a practice question for 187. We have a 28-year-old man comes to the clinic 2 weeks after a motorcycle accident. He reports difficulty gripping objects and numbness in the medial part of his hand. There's weakness of finger abduction and adduction. Okay, so that's actually ulnar in this question. Decreased sensation over the medial one and half of the fingers and hypothenar eminence. So ulnar is C8 to T1. So you have weak grip, inability to adduct the fingers. That's the interosseous muscle paralysis. And there's sensory loss. That's the medial 1.5 digits, the little finger and the half of the ring finger, that's the ulnar stuff, and hypothenar eminence. So that's ulnar nerve from the medial cord of the brachial plexus. So here's the medial again, LPM, lateral on top, posterior medial, and that's the ulnar. So the ulnar is damaged, and it's the medial, and you have to know it's C8 to T1. Could be posterior, C5 to C8, or C5 to C7 would be the musculocutaneous. And that'd be a sensation is like pinprick has decreased on the lateral part of the forearm if they were trying to get at something else like the musculocutaneous. But here they're asking for the medial, which is C8 to T1, not C5 to C7, which is musculocutaneous. So there they talk about musculocutaneous as a forearm flexors and lateral forearm sensation. Radial would affect the wrist and the finger extension, C6 to C8, and 5-6 is shoulder abduction. So there we go. Kind of fun. I like it. I'm watching too much Meat Canyon. Okay, a 62-year-old man with a history of chronic smoking presents to the clinic with increased shortness of breath. Chest imaging shows bilateral lower lobe infiltrates. Bronchoalveolar lavage reveals neutrophilic infiltration. Diagnosed with acute bacterial pneumonia. During immune response, elastase, released by neutrophils, contributes to the tissue injury. Which of the following enzymes normally counteracts the effects of elastase? And the answer is alpha-1 antitrypsin. So alpha-1 antitrypsin is a C protease inhibitor. It protects tissues, especially neutrophil elastase. So elastase breaks down elastin. And if you're not careful, you have nothing stopping elastase, you'll just destroy everything and cause loss of lung compliance. So alpha-1 antitrypsin deficiency causes unchecked elastase, so it tears everything apart. Pan-acinar emphysema in the lower lobes is what you get if you have alpha-1 antitrypsin deficiency, because we love alpha-1 antitrypsin. We don't have it, it's a really big problem. Lysosome hydrolyzes the bacterial cell wall. Myeloperoxidase catalyzes production of hypochlorous acid, bactericidal, but not elastase inhibiting. NADPH oxidase starts the burst. And elastin hydrolase, no, hardly nowhere. And let's just talk here about how inflammation can cause tissue damage. So if you have pneumonia, for instance, then neutrophils and macrophages are recruited to the site of the infection. And what are these neutrophils and macrophages going to do? Well, they're going to kill bacteria. But how do they do it? They spill their guts, ROS. So they've got like superoxide, right? That's what superoxide is, or hydrogen peroxide, or hypochlorous acid, which of course is this guy. And they spill those guts. And the ROS is generated by NADPH oxidase systems in the phagocytes. And reactive oxygenating species, they damage a lot of stuff. They damage the microbes, and that's why we love them, but we don't like them because they also damage the normal host tissues, especially if there's super high levels. Or if you have poor antioxidant defensive, or you have antioxidant defenses, or you have massive inflammation. And so the ROS mechanism of damage is DNA and RNA damage, protein oxidation, lipid peroxidation, mitochondrial dysfunction, and it can cause cell apoptosis and necrosis. If you have a patient who's got bacterial pneumonia, neutrophils are going to cause ROS to kill pathogens. And these ROS are highly reactive, and they can cause collateral damage to host tissues. And then that can then cause chest pain and productive cough. All right, for the next question, my computer's getting a little hot right now. I've got a lot of things going on. Let's talk about the pituitary gland. First of all, we got to know where it is. This guy. You go down a little bit. See? Let me give you a better view. You go down. Pituitary tumor. There's the blood. There's ADH. There's oxytocin coming out the posterior. There's our growth hormones, ACTH, all that good stuff. I really like this diagram of the pituitary. But as you can see, it kind of dips down right here. That's going to be super important in solving our next question. So we have a 45-year-old man, progressive fatigue, decreased libido. What's an additional finding on the visual field? It's bitemporal hemianopsia. Anytime you have a large pituitary tumor, like a prolectinoma, it'll compress the optic chiasm, and that contains crossing nasal retinal fibers. Then you have bad output there. So compression leads to bitemporal hemianopsia. But that pituitary can cause some problems there, causing bitemporal hemianopsia. There it is. So pituitary tumors grow upward from the sella turcica. Optic chiasm lies just above, contains the nasal retina that carry the temporal vision, and so it's compressed, you get bitemporal hemianopsia. It's not anything else like ptosis, that's the droopy eyelid, and that's related to cranial nerve 3 or Horner syndrome. All right, in this question we have a 28-year-old man recently returning from a hiking trip in the Andes. He's super high up there, and he took acetazolamide before going. Now he's got tingling and acidic pH, PaCO2 is at 32, bicarbonate 16. What's the primary acid-base disturbance? Interestingly, this is metabolic acidosis because he's losing a lot of this stuff. He's taking acetazolamide that's a carbonic inhibitor, so he has an inhibition of bicarbonate reabsorption in the proximal tubule. And then you have a respiratory compensation that explains the low PaCO2. And this is a challenging question because typically you'll see metabolic alkalosis when you're super high up, but here he took acetazolamide beforehand. If it were high altitude alone, it would be primary respiratory alkalosis because you have to hyperventilate to blow off the CO2, and that causes a mild decrease in bicarbonate over time, the renal compensation. That's primary respiratory alkalosis. But he took acetazolamide, and that's a carbonic anhydrase inhibitor, and that prevents the reabsorption of bicarbonate in the kidney. And so you lose it in the urine, and that causes metabolic acidosis, and that overrides the respiratory alkalosis that's caused by the altitude. So that's kind of a doubly hard, kind of a mean question. But the big thing to know about acetazolamide is it can also promote diuresis, and so you cause a loss of sodium, bicarbonate, and water. It's used to prevent high altitude sickness, but it's also going to be a side effect of volume depletion. And so high altitude also will exacerbate your dehydration problems because they have dry air, so you have less water that you drink. So the signs of hypovolemia can also take place. And if you're not properly hydrated, you could have lightheadedness when you're standing up. And there's also an orthostatic drop in your blood pressure when you stand up. All right, in this question, we have a 34-year-old woman newly diagnosed nephrotic syndrome is evaluated for fatigue. She has had worsening lower extremity edema for the past 2 weeks. Labs show low T4. Serum T4 is normal though, and the TSH is normal. What explains these findings? The serum total is low, but the free is normal. That means the bound is probably low. And if its bound is low, then the thyroxine binding hormone is probably low. So there's nephrotic syndrome. So you lose the thyroxine binding globulin hormone, causing a drop in the total because less is bound, but then the free stays there, because all these thyroxine binding globulin production is going to be reduced. And so there's less total T4 in the circulation. However, the free T4, so that is the biologically active form, and that remains normal. It's just the bound form that's going to get low. Also, one thing to note is that if you have like a liver disease, some sort of cirrhosis or something like chronic liver disease, you're going to have the total T4 decreases, but the free would stay the same. So that's another instance that you could see on test day. All right, next is 192. We're almost there, guys. We're almost there. Like and subscribe if this is helpful. A 58-year-old man is brought to the emergency department due to sudden onset dizziness, nausea, weakness of the left arm and leg. On physical examination, his uvula deviates to the right and has decreased gag reflex on the left. Okay, right then and left. Okay, got it. There is left-sided hemiparesis and loss of pain and temperature. MRI shows ischemic stroke. Which region is involved? So there's contralateral hemiparesis, the right side. That's just upper motor neuron involvement and the corticospinal tract. Ipsilateral cranial nerve finding. So the uvula deviates to the right, and gag reflex on the left means that we have a cranial nerve 9-10 dysfunction. So the medulla is localized. There's the cross sign for brainstem lesion, and our media medulla contains pyramids, medulla meniscus, hypoglossus, and nucleus. So it's the left medial medullary infarction. For another practice question, a 60-year-old man has sudden weakness in his right arm and leg, and his tongue deviates to the left. What's the location? Left medulla. It's a right-sided weakness problem, but the tongue deviates to the left, so it's left hypoglossal nerve and ipsilateral cranial nerve. So contralateral body weakness, ipsilateral cranial nerve palsy, medial medullary syndrome. So the tongue typically deviates to the same side here. Like here's another practice question: 65-year-old woman, sudden weakness of her left arm and leg, tongue deviates to the right, and so it's the right medulla. It's because there's a cross pattern, ipsilateral cranial nerve sign and contralateral motor weakness. Now, the reason why this happens is that the cranial nerves stay on the same side. They are ipsilateral. So the hypoglossal nerve controls the tongue on the same side. If the right hypoglossal nerve is damaged, the tongue will deviate to the right. But the corticospinal tract decussates at the lower medulla. And so the left brain controls the right side of the body and vice versa. So it crosses at the lower medulla. All right, next question here. So there is a 63-year-old man with a history of chronic alcohol use disorder. Physical exam shows gynecomastia, small testes, decreased body hair. What explains the low testosterone despite increased SHBG, sex hormone binding globulin? The answer is primary hypogonadism. It's because he drank so much alcohol and caused cirrhosis. So what happens is there's a decreased total and free testosterone. And so the LH and FSH go up because there's loss of negative feedback. And estradiol, due to the increased aromatization of androgens in adipose tissue and impaired liver metabolism. That's the important part. And we have this increased SHBG that's made in the liver because there's cirrhosis, which binds testosterone, decreasing the free active hormone even further. The albumin is low in liver disease, but this guy binds testosterone and it raises the bound testosterone while the free T drops. Now, there's another question you might see. Typically, it's going to be female, somebody who has some form of like a bulimic disorder, the purging kind. And you got to watch out for laxative abuse because then you can have hypokalemia, metabolic acidosis, and you have decreased bicarbonate and compensatory hyperchloremia. So whenever you lose bicarbonate, you have more chloride that usually takes its space, and then potassium is going to be lost as well. Because anytime you are doing a lot of bowel movements, your stool will lose potassium and also bicarbonate, and then the chloride will then take its place. All right, let's examine the lung real quick. Here it is in all its beauty. We have a pleural cavity, intercostal muscles, parietal pleura, and then the pleural cavity, and then the visceral pleura. So this part right here, important. Here's a practice question. We have a 32-year-old man admitted to the ICU after severe burns over 40% of his body. Okay, we got burns. Due to poor peripheral access, a central venous catheter is inserted via the right subclavian vein for fluid and medication administration. Shortly after insertion, the patient becomes tachypneic and hypotensive. Breath sounds are markedly reduced on either side. Oxygen saturation drops to 86% on high flow oxygen, and we have a sharp pleural edge with absent lung markings. Which of the following is most likely punctured? Is it the parietal pleura? That is involved, but if it's punctured, it won't collapse. And again, here is the visceral pleura, and then the pleural cavity, and then the parietal pleura. So here's another example. Visceral is actually on top of the lung there, and then there's this space, and then the parietal is on the outside. So parietal would not cause collapsing. It has to reach the visceral. Hopefully that makes sense now after looking at the drawing. Recurrent laryngeal hoarseness would be caused. Thoracic duct injury leads to xylothorax. That'd be the milky effusion, not the air in the space. So this is iatrogenic pneumothorax. Visceral pleura is punctured. So really it's those insane breath sounds, all the problems associated with breathing, collapsing lung leading to pneumothorax is when you puncture the visceral. You have more air into the pleural space now. All right, 195. So here we have a 28-year-old man who's got recurrent oral and esophageal candidiasis despite adequate glycemic control for type 1 diabetes. He has no significant past infections and is otherwise healthy. Genetic analysis reveals a mutation allowing the enzyme located at the granules of neutrophils. Flow cytometry shows decreased oxidative signal, and this NTB testing is normal. What explains the susceptibility to fungal infections? It's the impaired formation of hydroxyl halide radicals from hydrogen peroxide. Now, this is known as MPO deficiency. It's hydrogen peroxide is made normally and cannot be used to produce HOCl. So myeloperoxidase catalyzes the production of hypochlorite, and so deficiency makes it so you have recurrent candida infections in diabetic patients. You can't form the bleach and abnormal diphenhydramine flow. I think it'd be good to kind of visualize this. Here's our phagal lysosome, NADPH oxidase, superoxide dismutase, myeloperoxidase, HOCl. MPO deficiency would cause no HOCl, so you have recurrent bacterial infections because you can't destroy them. That's why we had more candida. It's autosomal recessive inheritance, and you have an abnormal DHR test. And that's how you tell the difference between CGD and MPO deficiency. So phagocytosis occurs normally. NADPH oxidase produces superoxide. All that's good. But then MPO prevents the conversion to HOCl. So you can't make the last step of the bleach. NADPH, you can't make superoxide. So hydrogen peroxide is there in MPO, but it's absent in both NADPH oxidase. And that makes sense, right? Because if it's upstream here, then that's not going to be superoxide dismutase and myeloperoxidase. All this stuff is gone if it's upstream. But here, myeloperoxidase is pretty downstream, and so you just can't create that bleach. So you have abnormal testing on both, but here, the NBT test is normal, but the DHR test is not good. All right, 196. So in this question, we have researchers that are analyzing dendritic cell activation in response to cutaneous antigen exposure. Skin biopsy is obtained, and one group of cells shows increased expression of the surface protein that holds the B cells on CD28 on T cells, enabling full T cell activation. Which marker is most likely increased? Now, here's a cool thing with CD28 is divisible by 7, 4 times 7 is 28. And that reminds me that B7, which is CD80, 86, is a marker of antigen-presenting cells like Langerhans. And that has an interaction with CD28 because they're divisible by each other. And without B7, the T cells would undergo anergy. And with my PEG systems, for those of you who followed along, remember I told you about those. 8 is V, 0 is S. So it's vase, dish. Remember vase and dish being presented to Langerhans cells, and that helps me get these questions right. Why are these wrong? CD3 is present on T cells, not antigen-presenting cells. Hot T bone, it's a pan T cell marker involved in TCR signaling. Hot T bone E found in the T cells would be IL-4 receptors involved in Th2 differentiation, and beta 2 is structural component of MHC, regardless of inactivation. So you need both B7 and 28. Yeah, here it is. Signal 1 is the MHC in the TCR, and then signal 2 is B7 and CD28. It's like you need 2 launch codes before you can really take this thing off. And that B7 is very specific for antigen-presenting cells. 197, we have a 5-year-old boy for speech delay, poor eye contact, hand flapping, protruding ears. All this makes us think of Fragile X, CGG trinucleotide repeats. It's the large ears, long face that give it away, and also the X chromosome maternal uncles are affected. Non-Klinefelters, that's not intellectual disability. No deletion on chromosome 15 would be Prader-Willi. Hypotonia, obesity, hypogonadism, and it's not red. All right, for 198, we need to know about the endometrium and its stages of the menstrual cycle. So there is a proliferative, secretory, and menses phases. And the secretory endometrium is characterized by dilated, tortuous endometrial glands. The proliferative is during the follicular phase of the menstrual cycle. And there you have a response to the lining of the endometrium to form. So the LH surge triggers ovulation, and the follicle becomes the corpus luteum. Progesterone rises and it acts on the proliferative endometrium. The glands coil and accumulate vacuoles, and then tissue becomes adenomatous. If no pregnancy, the corpus luteum involutes, progesterone drops, you get ischemia, and menstruation. 29-year-old woman has primary infertility. Her menstrual cycles are regular and occur every 28 days. She undergoes endometrial biopsy on day 22 of her cycle. There's tortuous, coiled endometrial glands with glycogen-rich cytoplasmic vacuoles. What stage is she in? Secretory. So the menstrual cycle has 2 ovarian phases. What we've covered before are the endometrial phases, but there are also 2 ovarian phases. There's the follicular, and the secretory phase is in the luteal phase, and it occurs after ovulation, so about day 14 to 28, driven by progesterone and the corpus luteum. It's the most receptive phase of the endometrium for the embryo implantation. Ischemia is before menstruation. The menstrual is the actual sloughing occurs. That's the fragmented stroma. And the proliferative is estrogen-driven before ovulation even occurs. You have long, straight, narrow without any secretions. That's the proliferative phase. So the secretory is post-ovulation. It's when the progesterone dominates. So just for the sake of getting this right on test day, days 1 to 5, you have decreased estrogen and the lining is falling off. That's the menstrual phase. Then you proliferate and you have increased estrogen. That's when the new lining is going to grow. And then you have secretory phase, 15 to 28. And there, it's progesterone that really takes charge. And the glands start to try to make food for the potential baby. So pick secretory phase if the glands are curvy, twisted, and the cells are plump with clear vacuoles, and the stroma is swollen, adematous. That's the secretory phase. That would be if you biopsy the second half of it. All right, this is going to be a good one for 199. So type 1 collagen would be implicated in osteogenesis imperfecta. Type 2 would be articular cartilage. So here is osteoarthritis. Type 3 is Ehlers-Danlos syndrome, EDS. Type 4 is Alport. 5, you hardly talk about it, but that could also be Ehlers-Danlos. 6 is also pretty irrelevant, but that's the extracellular matrix stuff. So if you see joint pain with activity that's relieved at rest, it's osteoarthritis, and that should make you think of 2. Pathophys, mechanical stress of aging, leads to the release of IL-1, TNF-alpha, and matrix metalloproteases. So here's our practice question. 62-year-old woman is involved with chronic left knee pain that worsens after long walks and improves with rest. It's osteoarthritis, and so it's type 2. All right, folks, question 200. The last question of MBME 27, or at least everything that I think that you need to know by the time you finish this exam. Of course, these questions are original, but very helpful, hopefully. There's a 3-month-old boy brought to the emergency department for cyanosis, afebrile, feeding well, no respiratory distress, vital signs are stable. Oxygen sat 84, does not improve with 100% oxygen. Ooh, okay. Arterial blood shows chocolate brown. His formula was recently switched to one that was mixed with well water. What's the most likely cause of his condition? Iron oxidation. He's got acquired methemoglobinemia. We have the Fe going to Fe3. You've got all the oxygen you could ever want. It's not going to solve it because it's formed wrong. Decrease 2,3 would increase the affinity, but not cause cyanosis or chocolate colored blood. Beta globin mutation is sickle. Alpha globin, alpha thalassemia, that's hemolytic anemia, not methemoglobinemia. Carboxyhemoglobin would be carbon monoxide. That causes cherry red blood, not the chocolate brown. So here's methemoglobinemia. The antidote is methylene blue. Give them blue because they're already blue. And here is a mechanism so you can kind of see how it works. That ferric, we get that Fe3 versus the Fe2, and so you can't bind no matter how much oxygen you give them. All right, guys, look at that. We have done it. I've given you 200 topics that I think are important for you to know by the time you finish your second exam. If you guys like this series, please like and subscribe. Many hours are going into these videos, and I want to make sure they're high yield and important for you. I would love if I could get up to 750 subscribers, and then once I get to 1,000, I'll start to work on 31. So please like and subscribe. Your subscription will directly be translated into more work and more content for you. It's free. You can always undo it later. I'm just trying to help you make your way through medical school. So with that being said, thanks so much for watching. You guys are the best. Let me know how I can make these videos better, and we'll see you guys on the next one.